Meniscus repairs do very poorly when they are stitched together surgically. And that's the topic of today's discussion. If you tear the meniscus, and this can often happen when playing sport where the meniscus gets a tear, or it can also happen as a degenerative type of tear because we're getting older. They can also happen if you happen to be a very young athlete and have what we call a discoid meniscus, which is a pancake-shaped type of meniscus instead of being a horseshoe type of configuration. So meniscus tears can happen from a very young age to an old age. And when we actually look where the meniscus is in the knee, going back one step, the meniscus is between the top bone, which is the femur, and the tibia, the bottom bone. And it's a rubber type of substance that allows shock absorption and distribution of load. It reduces degeneration. When we look at its configuration, the outside of the meniscus is called the red zone, and the red zone has a good blood supply, meaning it has a capacity to heal. And the inner 2/3, the white zone, has a poor capacity to heal. And again, that's in a nutshell the anatomical background on the menisci. Now, when you tear the meniscus, unfortunately trying to stitch it together produces poor outcomes. The data internationally very much suggests this. When we look at our clinical situation and patients coming in, if a patient walks into my clinic and they've had a meniscus repair, I'm very confident in the vast majority of cases we're going to have a problematic recovery. And the reason being is that the categorization of different meniscus tears gives us a lot more information about how ineffective or effective meniscal surgery is. For instance, a bucket handle tear, as the name suggests, if these are stitched, 80% fail. 80%. And for me, that's not a great number to be able to say to a patient that you're going to have increased pain, swelling and discomfort in the future. A horizontal cleavage tear, as the name suggests, it's a tear through in a horizontal fashion. These do very poorly with a repair. And like with the bucket handle tear, we don't suggest a stitching, but they do much better with a partial meniscectomy, a trimming of the meniscus. The same as the cleavage tear of the horizontal cleavage tear. These do much better with a partial meniscectomy. A complex tear, as the name suggests, lots of little fray parts. They don't do well trying to stitch them. They do poorly, and again, 80% of those fail if stitched. If it's causing catching and they're unstable fragments, a partial meniscectomy is the treatment of choice. I guess what we're trying to tell you with this is that in different categorizations of meniscus tears, their outcomes are poor with a surgical approach. And there's also, when I say the outcomes are poor, the stitches often come adrift. They pull out. They then float around inside the joint, and then they cause collateral damage to the other surfaces in the joint, because you've got these pieces of synthetic twine in the joint, and they often produce damage to what we call the chondral surface, or the bone above, the cartilage above, and will take big chunks of cartilage out. Not great for the knee, and again will produce premature osteoarthritis. Take-home message from here is that generally meniscus tears produce poor outcomes and often fail. And the challenge also with these, once they've been done, is that patients go through their 6 months of rehab or what have you. They continue to get pain and swelling. It produces more damage. The tear is not only, the stitch is not only come out, but it's often torn more. And then they have to go in for a second surgery to take the stitch out and also smooth some of the bone. So our advice is, again, err with caution if you're offered meniscal repairs. Now, I'm not saying that they don't work in particular patient populations, in the younger athlete. If there is a young athlete, because we know that red zone is bigger in the younger athlete that has a better capacity to heal. We know that if there's in the younger athlete population, and it can be stitched in some situations, but again in the general adult population, and definitely in anybody who's over 50 years of age, we know there's degeneration there. Be particularly careful about going through and having the meniscus repaired. So the take-home message: be careful about making choices about meniscus repairs, and certainly if you've got any questions or concerns, don't hesitate to talk to me. We have a good team of surgeons I work with here, and if need be, we can always send it for an opinion overseas. But the idea that meniscus repairs produce great results, be careful with that line of thinking. And to finish off, the reason why surgeons offer you meniscus repairs is because on paper it sounds plausible. Let's try and save the meniscus. Let's try not to take out the cartilage, take out the meniscus and trim it, because if you've got more shock absorption, that's much better for the long-term outcome. Look, I agree with that. That theory is plausible, but it's not the reality. The reality is, if I was to say to you as a patient, have this surgery, that's fine, but just realize that 8 out of 10 of these will fail and produce more damage, your ears would prick up and you would not go ahead and have this surgery or think twice about it. So that's often the case that's put forward by the surgeons in good faith here in Singapore. They're missing a point, and that is that they fail in a high percentage of cases. And the other point we see in Singapore is that the general patient population here that go and see surgeons are much more sedentary than other countries. In Australia, where I'm from, and even in our clinic here in Singapore, 95% of the patients I see are sportsmen. They, if they were going to have a repair of the meniscus, they expect to go back and play some sort of sport in jumping and landing in the future. And in that patient population, they always fail. Perhaps here in Singapore, they offer the meniscus repair more to patients because they see a more sedentary population of people, and the sedentary population, because they're not jumping and landing on it, do better with these. However, again, take-home message: err with caution if offered meniscus repairs. And finally, this is backed up in the data. When you sift through good international data on this, what I'm saying is backed up with science. Thank you.